Well, the challenges we face today are understanding, even though we have many therapies that are quite effective in the first-line setting, what are the resistance mechanisms that these cancers evolve that makes the therapy that has worked well now not work? So understanding that and coming up with new strategies is important. Since the 1960s, 1970s, we've divided lung cancer into two major types, small cell and what we call non-small cell, although non-small cell is made up of several different histologic subtypes. In general, it's easier to characterize the small cell population because the small cell population tends to be the smoking population. Small cell lung cancer is very tightly linked to smoking. So these are generally older smokers, and when you predominantly male-dominated patient population. When you combine smoking and aging, you get a lot of comorbidities. So these patients tend to have a number of different illnesses, cardiovascular illnesses, COPD, these sorts of things. And they tend to have issues with performance status and symptom burden. So I would say in general, it tends to be a tougher population to treat because of all of these issues that we've talked about. When you look at non-small cell, again, there's variation in non-small cell. Squamous is one that is also tightly linked to smoking, and it has very similar characteristics to the small cell population. But in the non-squamous, which is mostly adenocarcinoma, these are patients that may not have a smoking history at all. And that's a very different group of patients because this is the group of patients in which these molecular alterations are concentrated in. EGFR mutations, ALK translocations, ROS1, others that are there are principally seen in the adenocarcinoma, never or light smoking population. So again, that's in general, they're very different populations from a clinical presentation point of view. We have very different strategies for each of the subsets.